The disease affects approximately 1 to 4% of the population, so it's a fairly rare disease. It commonly arises after puberty, so around 20 years old is when the onset usually is. Women are 3 times more likely to get the disease than men. It's associated with a higher BMI level, smoking, and depression. Smoking and gender are the biggest factors that are correlated with a more severe disease. So the disease is broken down into 3 stages by the Hurley system. Stage 1, there's single or multiple areas that are affected, but the abscesses are separate from one another, and there's no scarring or sinus tract formation. In stage 2, there's recurrent abscesses, and they can be single or multiple, and there is scarring and sinus tract formation, and the lesions will be widely separated. In stage 3, there's large areas that are affected with multiple interconnected sinus tracts and abscesses across the total area. Case study. Chris is a 42-year-old male accountant presenting to ER with multiple lesions and swelling on his right buttocks. Patient states this has been ongoing for almost 20 years off and on again. Upon complete evaluation, the patient has a high BMI of 26. Patient admits to a history of smoking. He has been placed in stage 2 of the Hurley system. Patient has tried steroids and antibiotics in the past, but they were ineffective.
For our ICF model, James's diagnosis is hidradenitis suppurativa. His body structure and function impairments are his gluteal wound, pain, decreased lower extremity strength, and decreased lower extremity range of motion. His activity limitations include difficulty putting on his pants, antalgic gait, difficulty while weight bearing during sitting, and difficulty bending at the waist. His participation restrictions are he's unable to work because he cannot sit at his desk, he's unable to maintain a relationship due to embarrassment, and he's also unable to ascend his stairs up to his bedroom. A negative environmental factor for him is he lives in a 2-story home. However, he has positive familial support, and he's motivated to get better. Other personal factors that could inhibit his progression are embarrassment and depression. In our initial evaluation for James, we found him laying on his back with the head of the bed greater than 30 degrees. His cognition was intact and there was a large bandage over his wound, but there were no signs of infection. His sensation was intact in both lower extremities, and his strength and range of motion were decreased due to pain. He was able to independently roll in bed, but it was labored, and he needed contact guard assist to transfer from sit to stand. He walked with an antalgic gait, but he was able to ambulate 50 feet on a level hard surface with contact guard assist. However, he was unable to ascend stairs due to pain. As physical therapists, we recommended a 30-degree side lying position and rolling in bed every 2 hours for proper weight shifts. We suggested a waffle cushion for his chair for skin protection and heat and moisture dissipation. While sitting in his chair, we suggested weight shifts every 15 minutes for 60 seconds due to his skin grafts. We stressed the importance of getting up and getting moving. Additionally, we recommended lifestyle changes, including quitting smoking, diet changes, and wearing loose-fitting clothing. Our clinical decision scales for James's wound care treatment was based off of a study by Brohlman in 2013, which stated that donor sites covered with gauze dressings had a large increase for infections, and grafts with hydrocolloid dressings healed significantly faster than other dressings. Therefore, we recommended the discontinuation of gauze dressings and suggested hydrogel to donate moisture and promote tissue healing. We instituted the use of a contact layer for protection and a hydrocolloid dressing since there is minimal to moderate exudate and it's impermeable to contaminants, which is essential for his particular wound location.